Hi everyone, welcome back to the Nexus Academy. If you're still teaching or learning, today we are diving into a major medical transformation. We are breaking down how PCOD, polycystic ovarian disease, a localized ovarian disease, evolved into PCOS, polycystic ovarian syndrome, and why the modern medicine is now redefining as it is polymetabolic endocrinal ovarian syndrome. As future nurses and educators, understanding this shift changes how we assess our patient. So, how we plan their care and how we are going to counsel them on long term health. So, let's unpack the criteria, the clinical differences, and what this means for your next exam, your future practices. Let's get started. So, in today's session, we are exploring a vital concept in endocrine and reproductive nursing. So, the clinical evaluation of polycystic ovarian dysfunction. Specifically, we will trace how medical understanding transition from the PCOD to PCOS. And finally, how it is changed to polymetabolic endocrinal ovarian syndrome. Let us see. So mainly it is focused primarily on the physical appearance of the ovaries and also presence of multiple immature eggs, that means follicles that did not release. Often it is considered a temporary functional disorder rather than a lifelong conditions. And in this PCOD era, we looked at the way the ovary as the problem. If the ovaries looked polycystic on an ultrasound, we used to say that this is primarily diagnosis of polycystic ovarian disease. How this PCOD has transitions to PCOS in a syndromic view. So let's see the definition polycystic ovarian syndrome. Why this shift happened? Medical science realized that it wasn't just a disease of the ovary, but a syndrome, a collection of symptoms involving the endocrinal system. So previously in PCOD, we have been thinking that due to the cyst ovaries have, then it is a problem of ovaries. Then in the PCOS, we have found that the symptoms involving the endocrinal system. So there are multiple symptoms, multiple disorders can be seen here. So according to the criteria which we have taken from Rotterdam in 2003, this explains the 2 out of 3 must be present, like oligoovulation or anovulation, which is irregular periods, hyperandrogenism, which has acne, hirsutism, that means excessive hair, or biochemical lab results. So, and also the third is polycystic ovaries on the ultrasound. So this uh, this was a major shift from the PCOD to the PCOS. We began recognizing that the woman could have the syndrome if her ovaries looked normal, though on a scan, but she had irregular cycles and also has high androgen levels. So here you can see the healthy ovaries and polycystic ovaries. It's nothing but in the PCOD we have concentrated on the ovaries. Here we involved the endocrinal system, all the symptoms which are related to the irregular menstrual period. Let's see how PCOS has uh, transformed into PMEOS. So the definition, polymetabolic endocrinal ovarian syndrome. It is a global shift. This nomenclature emphasizes that the metabolic component, that is insulin resistance, is often the driver of the hormonal and ovarian symptoms. So what is happening here? It is also involving insulin resistance, obesity, and risk of type 2 diabetes mellitus. So endocrinal, which is imbalance in the luteinizing hormone, follicular stimulating hormone ratio, and elevated androgen levels. And the third is the ovarian, reproductive challenges, and follicular cyst can be seen. So these three key components has been found in the PMEOS. So this tells us that the ovary is the victim of a larger metabolic fire. So by treating the metabolism, diet, exercise, insulin sensitizers, we can fix often the ovarian symptoms. Okay, let us see the comparative criteria, how PCOD and PCOS, PMEOS, how it is different, how it has involved to a PMEOS. Let us see the primary focus during PCOD, it was ovarian anatomy. In the PCOS, it was hormonal imbalance. And now in a modern era, PMEOS, metabolic and insulin health. The main symptoms we used to see in the PCOD, mostly we used to concentrate on cystic ovaries. In the PCOS, hirsutism and irregularity. Hirsutism means excessive hair on the face, chest, abdomen. And PMEOS, insulin resistance and weight. Next, impact. So in PCOD, we used to think that it is localized, especially we used to concentrate on fertility. In the PCOS, systemic and also endocrine. Now, lifelong and metabolic risk can be seen in the PMEOS. Treatment. So mostly used to concentrate on surgical hormonal. In PCOS, hormonal birth controlling pills. Now, when we talk about the metabolic PMEOS, lifestyle and metabolic care. So, as I said, that exercise, diet can change. Uh, Better ovarian health can be seen. Let's see the clinical implication per nursing care. Patient education. Nurses must counsel the patients on lifestyle modification, on not only on the just medication. We need to concentrate lifestyle modification, diet, exercise, etc. Screening. Patient with PMEOS need regular monitoring for blood sugar and lipid profiles. Holistic approach, addressing the psychological impact of hirsutism and infertility. As educators and clinicians, we must shift the patient's focus from the fixing the period to the managing their metabolic health for long-term wellness. Hope you have understood. Thank you.